Two speakers.
Siddhartha, can you say something?
Yeah,
Let's see.
can you hear? Can you hear?
Yes.
Yeah, no
Can you
echo.
hear us?
Yes, we can hear you. I don't hear an echo. Everything seems to be fine.
Perfect.
Perfect.
Okay.
All right, should we get started?
Let's get started. Shani's welcome. Yeah, she's coming. Yes. Siddhartha, you want to start the introduction?
Sure. Well, hello, everyone. Good afternoon. Welcome to the PhD dissertation defense of the Khadija Zaidi. You know, this is usually one of our most favorite events of our academic careers, having students defend their dissertation. So I'm delighted to welcome you all to Khadija's defense. Khadija graduated from Westville High School in Centerville, Virginia in 2008. And then she received her Bachelor of Science in Bioengineering from the University of Maryland at College Park in 2012. And then she joined the bioengineering program at Mason, where she has been working in a couple of different labs. So she's going to talk to us about her work on multi-scale representations of functional movement. So just a couple of logistical things. So during Khadija's presentation, I would ask the audience to please hold your questions. The committee members can ask some clarifying questions if they would like, but we'll have a question and answer session after the presentation where folks can ask their questions. And at the end of that, we will have an executive session with the committee. So at that time, we will ask the audience to please excuse themselves. So with that, Khadija, please take it away.
Thank you very much, Dr. Sikdar, Dr. Ray, Dr. Ross, and Dr. Laskey. Again, my name is Khadija Zaidi. Good afternoon to everyone. And I will be presenting a quantitative analysis of upper extremity severity, impairment severity, and dissimilarity after stroke, and discussing a few different representations of functional movement. There we go. Okay. So the least movement in our bodies is evidence of a robust and meaningful conversation between the brain and the environment around it. Movement is one of our most critical survival needs. In fact, might even be our most significant survival need. This movement is necessary to eat, to talk, to take care of ourselves and our children, and to even be in this room today. Now, over the course of the last 150 years, motor control theories of how the brain organizes movement have been evolving. Initially, they focused on the underlying neuronal mechanisms and how the brain organizes movement through specialized subsystems. Now we also have mathematical and behavioral models available to us to model body mechanics, how sensory feedback is incorporated, how errors are corrected, and how motor learning occurs. The human motor system, composed of many muscles and many joints, is able to create a wide variety of movements to complete a simple task, and conversely can also complete many different tasks with the same movement. This is what we call redundancy or motor abundance, more recently is the more correct term to use. And now this variety in movement, this variability, this abundance, can be described by, in part, a few different factors that produce variability. One of them is the variability caused by practice and memory amongst individuals. For example, athletes have a bigger body of practice and have specific specialized movements. The variability in body regions that are involved in any given movement, the way that perception and action are incorporated in ongoing control and in error correction, and the variability in endpoint outcomes. But no one motor control theory covers all of these, and no one motor control theory is complete. There are many open research questions for us to ask ourselves. When we begin to classify and categorize movement of the upper and lower extremity, in the case of the lower extremity, we are capable of stereotyped continuous linear movements like running and walking. And we can also perform discrete movements that have a definitive beginning and end, like kicking a soccer ball. The upper extremity is capable of all this and also capable of non-periodic and non-linear movement. So it is a behaviorally and computationally far more complex problem to solve. The upper extremity also features degrees of freedom in each joint that causes also another contribution to the variability and motor abundance. And in 1967, a theory created by Bernstein describes how coordinated movement can occur in such a flexible and highly nonlinear system is by constraining control variables. That's the initial description of coordination. And I hope we'll talk again about definitions of coordination as we go. Contemporary studies look at coordination as covariance, multiple kinematic parameters changing together. So why is all of this important? To bring up cerebrovascular accidents, or as we more commonly know them, strokes. Stroke is the second leading cause of disability in the United States today, with 15 million people experiencing a stroke every year annually. Strokes can be of two different categories. Just under 90% of all strokes are ischemic in nature, which are caused by a blockage to the blood supply of the brain, through clots, embolisms, and cause very rapid tissue death or lesions. And hemorrhagic strokes are the other variety of stroke, where a sudden brain bleed pushes and causes pressure on the brain, which also creates lesions. And these lesions disrupt the communication between the motor apparatus and the musculoskeletal system, by preventing downstream motor neurons from receiving signaling. About 80%, figures are different, between 50 to 80% of all stroke survivors experience hemiparesis in the chronic stage of stroke. So that's the 6 months after the stroke event has occurred. You'll hear me later on saying paretic, or more affected, or contralateral. Generally, there is greater evidence of functional limitations or greater impairment severity on the opposite side of the body. So if the lesion is on one side of the body, the contralateral limb will be the one on the opposite side, which is now being referred to as the more affected, because of course all sides of the body are affected, but the contralateral one tends to give greater evidence of limitation. Although there exist several objective measures of upper motor performance, in the research setting, such as electromyography or motion capture, these do not translate very well to the clinical setting, and the clinical setting still prefers to have subjective studies. So here you see an example of 6 different hand tasks that are a part of the upper extremity Pugel-Meyer assessment of motor ability, which is very frequently used. In it, clinicians will ask you to complete a task, or complete a movement, and score it from 0 of complete inability to complete that movement to 2, movement without difficulty. Now, because this is an observation and it's a subjective evaluation, it cannot differentiate between restitution, true recovery, or through compensatory maladaptations. It's largely subjective, may be different between clinicians, what score that they ultimately give a patient, and they cannot detect slow improvements or explain underlying deficits. Because current metrics are generally focused on the movement of the hand or endpoint kinematics, even the objective scores that we use do not represent the upper limb as a multi-segmented model. In stroke rehabilitation in particular, there's currently no consensus on which kinematic metrics are comprising of a standardized comprehensive scale of upper extremity performance. So we have a gap in knowledge and a crucial research question. How can we develop a method for assessing upper extremity coordination and movement after stroke that is sensitive to impairment severity, is sensitive to age-related differences, because strokes, generally the risk for a stroke increases every year after 55. So it is a aging population generally that is being studied here. Can it identify specific behavioral limitations? And the most crucial question, can it be transferred to any movement? Can it be transferred to any clinically produced data? Can it be transferred to any part of the body? So these are some of the questions, sub-questions that we'll carry forward into the AIM study. So our first aim, our first preliminary study that we developed to generate hypotheses, was to characterize upper extremity movement performed by healthy volunteers and look at how ataxia or disruption to interjoint coordination shows up in the data after a stroke. And this is, we hope, going to answer the first 2 questions of what are the significant descriptors of upper extremity performance, and how does motion captured data produced anywhere in a clinical setting, how does that depict functional limitations or disruptions? Now, what we expect to see, despite this being a hypothesis generation study, we expected to see that there would be segments between the upper arm and the forearm that will look similar, that will be congruent in shape, and that this will occur in the first 30% of movement. Behaviorally, we know that when we reach forward for something, our shoulder and our elbows are the ones reaching forward, and the hand is not having a lot of variability in the movement. So that's what we expected to see. Any correct representation of the movement of the upper arm, we also expected to see in that the forearm and hand segments would show congruence toward the ending of movement. So when movement is completed, when fine motor control takes over. And we also expected to see that the mild impairment subject would show some segments of congruency that are similar with those two joint pairs. We expected to not see the same level of congruency in the severe impairment subject, but for there to be some level of disruption evident in both. We expected that the disruption would come as a delay in where that congruency occurs. So we selected a functional task reaching to a target, which was selected because of its ability to identify motor deficits after stroke, for its ability to provide a significant amount of data, and for the fact that it incorporates the shoulder, the elbow, and the wrist joint in this simple task. It's a subtask, a movement primitive, if you will, of many activities of daily living. So I will play this for you.
To perform this exercise, you're going to sit in a chair at a table. Your affected arm is going to be resting on the table. Your shoulder blade is going to be down and back. And from this position, you're going to reach out like you're grasping an imaginary object and bring it back in.
This is the exact movement that was performed by all of our subjects.
To perform this exercise, you're going to sit in a chair at a table. Your affected.
Now, reaching also displays characteristic movement peaks and discrete kinematic landmarks, such as peak acceleration, peak velocity, and peak deceleration, which coordinate with the triphasic muscle activation pattern, which is also evident in reaching when the biceps and triceps modulate the elbow extension component of it. So we expect to see a lot of data.
ये सिर्फ 8 महीने का हुआ तब ये रस्सी के सहारे उल्टा लटक जाता था और जब ये 9 महीने
I didn't mute him. All right. Okay, all participants were drawn from the MedStar National Rehabilitation Stroke Patient Pool. We recruited 2 able-bodied volunteers and 2 volunteers from the patient pool, one of whom was a person classified as mild impairment because their upper extremity Pupil-Myers score, right here, was between 30 to 66. 66 is the highest score that you can receive on the upper extremity test. And our second subject was one with the score between 0 to 30. So they were classified as the severe subject. And all subjects had clusters of position sensing infrared sensors that were worn centrally on each segment of the upper extremity. Now I can show you an example of what the movement analysis, the motion capture data looks like. This is somebody who is an able-bodied control, and we have our stroke subject here. We can make some clinical subjective observations when looking at these videos. For example, there is more evident differences in peak velocity. There is more distal limb segment impairment. If you see the red marker, this is the hand. So if you imagine the person standing over here and reaching forward into the positive y direction with cluster of 3 on the shoulder, on the elbow, and on the hand segment. We can see some differences in movement smoothness. Now, of course, this is only evident after the data has been filtered and signal loss has been addressed by extrapolating from nearest neighbors. Because one of the drawbacks of using position sensing markers is signal loss, incidence of noise. And to translate these subjective observations that we can make here, we must create a standardized protocol that can identify time location of limitations that can then be compared to time locations of the peaks of velocity and acceleration and deceleration. And we expect to investigate also the interaction of joint pairs behaviorally and to match it to the progression of the data. So the movement analysis methodology is based on a distance calculation called Procrustean distance, which is actually named after a bandit of Greek myth who used to stretch the limbs or cut off the limbs of his victims to make them fit. And that is actually an appropriate description. If I can have your attention here. If you assume that that black circle is supposed to be made to fit into the red circle, the translation occurs to match the centroids of both parts of the data, so that both of them are centered at their mean. For scaling, it is changed in scaling so that the root mean square difference between it and its mean becomes 1. And finally, they are rotated and reflected by comparing each ith element of one curve to the ith element of the other. We also have a video representation of this. Okay. So you have scaling, you have translation, you have rotation or reflection. And using these coefficients, you are able to compute a dissimilarity index, which is the square root of the summed differences of all individual points that have been matched. And that gives us the advantage of using this methodology. It gives you specifically what those differences look like in terms of scaling, translation, rotation, and reflection. We used fixed sliding overlapping windows with a 97% overlap, and I'll show you a visual representation of what that is. Essentially to segment all curves into all possible subsegments and to use Procrustean distance to analyze congruency between the window when it's on this curve and compared to the window on this curve. So what this allows is a continual analysis of the data. The modified Procrustean analysis is more likely to consistently and accurately identify changes due to this fixed sliding overlapping window methodology. And it can accurately identify a submovement that is replicated in both. With upper extremity movement, there are so many potential submovements that may converge into any given peak that it is difficult to look at analysis just in terms of peaks or segmenting data based on discrete landmarks. However, this methodology, I show you here with this is our subject, it compares every possible subsegment between both to find the location where the greatest congruency occurs. The greatest earliest congruency occurs. Once it analyzes everything, it's telling you this is a location where the greatest congruency was found based on a threshold value. And here is the advantage of using a sliding window with a set size is that you can also compare a stroke patient's data against a reference data set. So here, these figures depict the reaching movements completed by our two able-bodied subjects. All movements begin in the lower right and extend forward into the positive y-axis. So if you imagine the person where that icon is, reaching with their arm into the direction of the target, which is placed centrally in front of each person. The overlay with the greater weight over here, that is the output of the Procrustean analysis, which highlights the area of the greatest congruence, the earliest and greatest congruency, or the least dissimilarity index. Okay. So if I can begin at the bottom graphs. This congruency between the wrist-elbow joint pair occurs at the initiation of movement, and this congruency is occurring at closer to completion of movement. And this is consistent with behavioral descriptions of movement in that the elbow and wrist do not require much modulation during the initial ballistic movement forward, and that this is where you're seeing the gross motor control, and here where you're seeing the fine motor control towards my apologies. You're seeing the fine motor control occur at the end here. The shoulder and elbow do not need to work separately towards the ending of movement. Once they have reached the majority, the maximum distance that they can reach, the hand is the one that takes over with the fine motor control. And we see the same behavior with control 2, with the initial congruency occurring between the wrist and the elbow, and the completion congruency occurring between the shoulder. So keeping this in mind, if we look now at our mild subject, on here, subject 1, and our severe subject, we'll see that the congruency that was expected here towards movement completion does not occur. It occurs earlier in the movement, which we weren't initially expecting to see. And this movement, this congruency, which was expected towards the beginning of movement, there's a temporal mismatch. So even though these appear to be congruent to one another, they do not occur during the same time. And for our severe impairment subject, they are further delayed rather than occurring towards the initiation of movement. So because the algorithm looks for the earliest time when there's congruency, means that there may be some congruency earlier, but the least one that is also the earliest occurs actually much farther into the movement. This is consistent with our subjective behavioral clinical observations of the subject as they were moving. Okay, so our key findings from this preliminary study were that both controls showed congruence between shoulder-elbow joint pairs and elbow-wrist joint pair, and that they were differentiated by where they occurred within the movement, with the shoulder-elbow happening during completion and with the elbow-wrist happening during initiation. We found in the stroke subjects that there is a delay in when those congruencies occur with stroke patients. And specifically, we see with the mild impairment case that there was a temporal mismatch. So that would essentially not be considered a congruency because they're not occurring in the same time point. Of course, the biggest limitation of this study was small sample size, just to generate our hypotheses. We also found that while upper extremity kinematics can be effective descriptors, they cannot be taken in isolation, but rather need to be complemented with another data source with more information to be able to identify which are the specific kinematic metrics that will provide the best explanation for the variation. So this brings us to our second aim of characterizing endpoint differences between groups of stroke survivors that differ in impairment severity in order to create an objective dissimilarity and severity score. Questions we hope to answer with this question was to further understand how to segment motion data into congruencies, how to characterize them into phases of interest, and what parameters and methodologies will be significant in creating sensitivity to severity. Because while there are many treatment interventions and plans for subjects with mild impairment, there has not yet been as much proposed for subjects with more severe, more distal impairments. What we expected to see was that there would be some acceleration of related congruencies. So acceleration usually occurs in the beginning of every muscle movement. So we expected to see that mild impairment subjects would show some congruency that's analogous to healthy movement occurring in the movement initiation phase. We expected that severe impairment subjects will not exhibit any congruous segments of movement. We expected that the severe impairment subjects would also be in the kinematic analysis would also show limited range of motion and would show higher magnitude of percentage error in reaching the target. And finally, we expected to see that arm dominance and severity of impairment will have either individual effects or combination effects on the temporal location and length of the congruent subjects. And if I can discuss with you the summary indices that are currently used for the lower extremity, methods are far more accessible. The upper extremity is comparatively limited compared to gait analysis and still relatively under construction. So as we're moving towards creating motion capture data sets that are much, much larger and with a greater amount of information that can be extrapolated from that, it's necessary to create summary scores that can be done without visual inspection, without somebody reviewing the efficacy of the algorithm. So it must incorporate kinematics, dissimilarity indices, and the confirmation coefficients that are generated by Procrustean distance. Even in gait analysis, there is a continued preference for subjective screenings in the clinical setting, despite there being these methodologies available in the research setting, such as gait profile score, deviation index, Gillette gait index, all of which are based on Euclidean or root mean square distances between reference data and individual data. The summary scores that are currently available for the upper extremity include arm profile score, which utilizes root mean square distance to create 13 subscores that define each aspect of the arm. There's also a pediatric upper limb motion index that is currently in use for unilateral impairments caused by cerebral palsy in children, which is a composite score. So it is relatively well validated using these distance measures to create a summary quality index. Also, for the purposes of kinematic analysis, we looked at speed, we looked at mean velocity, peak velocity, time to the peak velocity. We looked at accuracy by looking at target error and spatial overshoot. And finally, we also looked at functional ROM, looking at the range of motion for the endpoint. So with stroke patients, especially ones with more severe impairments, it becomes difficult to use position sensors because sometimes functional activities will occlude the sensor from being picked up. There will be a greater amount of signal loss. For that reason, these subjects were all only fitted with one infrared marker on either endpoint, so either hand, with target placed centrally at 80% maximum capacity, reaching capacity, and a light signal telling them to move to the target 10 times during each session. We took that raw position data, created a velocity profile, and the orientation profile, which are the parts of the kinematic analysis, which will go on to become severity scores, and the modified presence analysis, which will go on to become the dissimilarity score. Just to give you a quick reference of what our velocity profile from our reference data looked like. We asked healthy individuals to move at a steady pace. This was their best attempt at trying to keep their velocity very steady throughout the movement, and then their attempts to go as rapidly as possible. And all subject data was compared to both of these. And these are just some examples of what the velocity profile looked like for the mild impairment group. Generally, these are only 3 subject samples, but generally the peak velocity occurred slightly more later during the movement compared to our reference movements. And these are only a few. This is not what all of the severe impairments patients look like, but generally they had their peak velocity occurring at the extremes of movement. So either the fastest movement they were able to achieve was right in the beginning in response to the light signal, or it was towards the end after an experience of distal impairment to try and complete within a given time. Because all of them were given the prompt to move as quickly as possible. Okay. Endpoint orientation is a whole other research question unto itself, so I'm not going to go into too much detail about it. But for the purposes of evaluating differences between the groups of stroke survivors, we opted for the angles of yaw, pitch, and roll. And the most important one for us is the roll. Is with patients that have increasing severity, we generally noticed in the clinic that they would compensate with shoulder involvement, with trunk involvement, and raise the arm in the absence of the ability to actively extend it. So we focused really mostly on roll angle, because of course, known issue that gimbal lock problems will occur when attempting to extrapolate orientation angles from position data. So these are 2 example graphs of really seeing the most variability happen in the roll angle. These are not reliable measures because of the gimbal lock, but we're able to see that there is some variation that we can pick up in the roll angle and find our range of roll angles that are. We did 2 things with procrusting distance. We broke each segment down into 10 parts to look at the dissimilarity indices when comparing it to the steady reference. These are all compared to the steady graphs created by our healthy volunteers, and these are compared to the rapid ones. And in all of these, we found that towards the ending is where the larger dissimilarity occurs. And upon evaluation, we found that this can be a important differentiator and descriptor of severity, degree of severity. So that was included later on in the dissimilarity severity score. Now, these are initiation movements in the mild impairment group. So all of these are 3 subjects who are here being compared to the steady reference and here compared to the rapid reference. And in each, if you will imagine the person sitting here and using their outer limb. So here, this is a right arm movement. And this is somebody who was paretic on the left side using their left arm to move into the direction of where the target was placed, 80% maximum capacity in front of it. Okay. It's difficult to see the black lines here, but if you look at the shading over here, the reason it is difficult to see is because most of these graphs have a very good overlap. There's a great amount of congruency occurring in the beginning. So our mild impairment subjects typically showed that they had the earliest congruency occurring during movement initiation. So this is consistent with behavioral analyses where the ability to move forward is preserved, even with mild impairment. These black lines will be a little bit more evident in the next slide here. So you'll see right there. These are each matched data points. So if you will assume this is a sliding window right here, with this is 0.1. 0.1 is compared to 0.1 of the other segment in order to evaluate the confirmation coefficients of scaling, translation, and rotation. So you see temporal mismatches occurring with severe impairment subjects. The earliest congruency doesn't occur during movement beginning, during the beginning of the movement. Some did still have some congruency, but this one is actually not temporally matched here. These are all our severe subject exemplars, just 3 subjects from a group of 14. And they did not have consistently located congruous behaviors to reference movement. So taking the metrics of mean velocity, the roll angle range of motion, and the the high target error. Using those, we composed a severity score. And using the analysis, the Procrustean analysis, we created a dissimilarity score. And then the ratio between these two was used to compute whether or not that person, that individual, should receive a speed emphasis or a strength emphasis. And we can show it here in the mild group. Everyone who was classified mild by the Fugel-Meyer score generally did not fall under the requirement of a speed emphasis. And this is subjects with a higher severity indices, but lower dissimilarity. So still able to be analogous to healthy movement. And this is due to low mean velocity, low peak angular values, and high target error. That was what was given the strength emphasis. And finally, subjects with comparable severity and dissimilarity scores, so a ratio closer to 1, they were given a combined emphasis. And of the 15 subjects in the mild group, 0 for speed, 10 in the strength emphasis, and 5 in the combined, which is consistent with the clinical observation that persons with mild impairment continue to be able to reach forward quickly, while compensating for muscle weakness and loss of agility. So now we come to our third aim of identifying age-related differences in upper extremity bilateral tasks, so tasks that require movement from both arms and requiring interlimb and intralimb, or we can call it interjoint coordination. So coordination between the 2 arms to create a symmetric movement, and also coordination between the shoulder, elbow, and wrist segments. And these are some of the questions that we most received during our review of the previous manuscript that was accepted. Can this quantitative score be transferred and be sensitive to age-related differences? Can it recognize multi-segment coordination? And can it be transferred to any clinically produced data? And can it be transferred to a different body region or to a different movement? These were the biggest questions that we received. So to that end, we developed this final study where accelerometry was used instead of position sensing, so that we could have a higher variety of tasks. Generally, functional tasks are difficult with motion sensing, especially one where you might need to move inwards and might rotate the sensor away from the camera. So we expected to be able to see age-related differences with accelerometry, specifically seeing lower angular velocity in the group with a higher mean age, greater angular range of motion with the group with a higher mean age, and slower angular velocity. We expected to see that group 1, which is the younger group, so that's from 18 to 30, that they will demonstrate greater intralimb coordination, so greater movement with more energetically efficient movement of the arm, with more coordination between the shoulder, the elbow, and the wrist segments. And that would be characterized in the movement initiation of every symmetric task and towards completion of asymmetric tasks. Essentially, we thought people who are younger will try to do this faster. Group 2, which is from 35 up to 75, we expected for them to demonstrate elongated interlimb coordination. So more coordination between either side And there's a theory of age-related ambidexterity, where lateralization or one-handedness decreases with age. So that was the logic behind expecting to see elongated interlimb coordination, and have that be indicated by how long the segments are that are found through the what we're going to call the expanding procrustes methodology. So this is kind of an example, a little bit of what it would have looked like if we had used our original position sensors to do this study. There would be a lot of wires, and despite all of this, there would be a lot of signal loss, and there would be a high level of noise with the movements. So also, position sensors ultimately only provide one stream of data. They're not without unignorable constraints of cost. Position sensing systems, generally, you do not find them in the clinical setting. You find them a lot in the research setting. And so because of this, it doesn't transfer well if we were to use position sensing. So in order to use a method which would give us different streams of data and would also reduce costs, reduce patient burden, we opted for accelerometers that were combined with magnetometers and gyroscopes into inertial measurement units, which in lower extremity studies have already been shown that a single sensor can characterize the phases of lower extremity movement. So in our quest to create a highly transferable quality score, we opted for these commercially available triaxial accelerometers and inclinometers. I have a picture of how they were placed. Each subject seated during the first task, and I'll go over the 3 different tasks we used. They were as centrally located as possible sensor on each limb segment. So in the middle of the hand, between the fingers and the thumb, on the forearm segment and on the upper arm segment. And each was oriented so that the forward motion is in the positive y direction. And all of these accelerometers sense the acceleration relative to gravity. Okay, so in order to select tasks that will be important for age-related differences that will be sensitive to them, you can classify bilateral upper extremity coordinated movement into 2 overarching types of symmetric and asymmetric. Symmetric tasks, for an example, clapping is symmetric because it requires both of your hands to be in phase with one another. Driving is anti-phase because if you're placing both hands, you are doing different things with both hands, but it is still symmetrical. And these tasks are increasing in complexity as they go, with drumming is complex phasing. Asymmetric tasks can be tasks that are complementary so that you're using both arms to still complete one task or one attribute of movement while feeding yourself. Or they can be completely independent of one another, like rock climbing, where your arms, you do still need both arms and you do still need to coordinate in some sense, but they move independent of one another. So again, these are more and more complex. So we would expect to see with somebody with age-related decrease in velocity, age-related decrease in coordination, that these tasks would get progressively difficult. Okay, so these are representations of the 3 tasks. Is it okay to have this overlay over this one? That one is our task 1, our easiest task to complete, which was a reaching forward to a target with both arms, with the target placed within arm's reach, so that there's no trunk involvement and minimal shoulder burden to reach forward. And when that looks like, what that looks like in a session of 10 reaches is very much coordinated between the upper arms. So you have the red, you can't even see because of how much they are matched between the right and the blue in left, the left arm. The forearms show differences from the upper arm, but they are coordinated with one another. And the hands, again, as expected, are completely symmetric and in phase with one another. For the second task, we had a vertical column of 4 buttons, with each person reaching to the first one with both arms and raising their hands to each one as they go. And that created this stair effect during buttoning, where you see your first initial movement is coordinated, and then there's some variability over here as each button is being unbuttoned. These longer ones are these are buttoning, and this is unbuttoning, which was a relatively easier task. So this is broken into two different tasks, one which is still a bit more symmetric than the other. And then finally, the third task was for a person to reach into a cabinet placed at eye level and to open it and reach in for an object with the other hand. So we don't expect to see any matching, which is exactly what the data shows, that there is somewhat complementary phasing, but not symmetrical. So we went from totally symmetrical to somewhat symmetrical to completely asymmetric and independent phasing. So these bimanual tasks were specifically chosen as functional tasks, so they will feature some combination of reaching and manipulation, and that there's differing amounts of symmetry that we can expect behaviorally. Okay, we show how here the absolute values of minimum and maximum angular velocity and peak roll angle, so the range of angles that are were demonstrated, and we evaluated if there were significant differences in angular velocity between the groups. The upper arms experienced the least velocity during forward-reaching movements compared to the hand segments, which throughout all the movements tended to have the highest velocities in the finer precision motor control phases. Roll angle of the upper arm or rotation about the y-axis showed significant differences between the groups, particularly in the right and left upper arms and in the dominant hand. All subjects were controlled to be right dominant. And asterisks here indicate all the quantities where there are significant differences between those subjects. So these would be the arm components, and the task-specific requirements have caused these arm components to differentiate between these two groups. So we see the dominant arm having the forearm having a more significant difference between the two groups. Again, that could go into dominance or one-handedness decreasing with age, and the left upper seemed to be significant between the two groups. And with the roll angles, we see that there was, for the rotation around the y-axis, it showed most of the differences particularly in the upper arms and the dominant hand. And these findings are all consistent with prior knowledge of age-related differences, so slower angular velocity and increased angular range of motion, as there's a attempt to compensate for the lower angular velocity. So these are all consistent with behavioral descriptions. In order to compute interlimb coordination, the fixed sliding overlapping window method was still used to segment, but also supplemented with a point-by-point expansion, both forward and backwards, to identify temporal boundaries or locations where the dissimilarity index increases beyond a 15% dissimilarity. And that 15% threshold was selected based on individuals and the difference between movement beginning and movement ending. Generally, that is the median dissimilarity score we achieved with our previous study of having 30 subjects. So that's why the 15% was selected. Segments that where the initial congruent segment that was initially found was already above the threshold of 15 were considered to demonstrate a 0% of similarity. And segments where they are not temporally matched in task 1 and task 2 also not considered to show any percentage of similarity. And both groups demonstrated high percentage of similarity for the first task. So that's this picture here. That is the reaching from below the table and up to the target forward. And there is almost a complete coordination between the two tasks, between the two arms. These are the four arms. And we're able to generate the same analysis of the upper arms and the matched hand segments as well. During the buttoning task, we see the coordination as intuitively expected, only when the arms are both reaching forward towards the button, and then not anymore when the arms are engaged in the hand variability between the buttoning task. And then in the final column, we see in the third graph, comparing the right upper to the right forearm during the cabinet task. So and interlimb and intralimb coordination scores were computed based on these temporal locations that were identified by that expanding percussive methodology, and a higher percentage of similarity with a lower dissimilarity index together show a higher quality score. So we divided each percentage of similarity by the dissimilarity index of that particular segment. And that quality score was then normalized logarithmically. so that we can then compare interlimb and intralimb coordination between these groups. So here you have your percentage of similarity for group 1 and quality score, and the tasks we broke down into 4, since buttoning is separate from unbuttoning in terms of the quality of the movement. Okay. Any study of motor abundance or non-periodic upper extremity movement is going to be incomplete without assessing the impact of bilateral movement. You'll recall earlier I said the more affected arm, meaning that the other arm is still affected. It may be the less affected, but it is necessary to begin rehabilitation with both arms rather than simply focusing on the paretic arm or on the dominant arm in order to preserve quality of life. When evaluating the percentage of similarity between we found the group with the higher mean age, so that's group 2, produced coordinated movement during buttoning that was not present in the younger group. There is still some coordination that occurred during buttoning for the older group. And one possible explanation for this might be that the older group included a lot of parents who do button other people's shirts, whereas maybe the younger group doesn't have the same body of practice of buttoning, somebody else's shirt. That could be one possible explanation for it. Or it could be a compensatory adaptation of some coordination still occurring between the two arms while buttoning for group 2. And then we found that for the younger group, they were able to produce more consistent quality scores in the intralimb. So the actual energetically efficient movement and moving your limb segments synergistically, the younger group shows greater consistency even as the task increases in complexity. And your group with the higher mean age is able to show some interlimb coordination that is not present for the younger group. So the upper extremity, we know, particularly our hands, play a crucial role in daily activities. And with age, it undergoes a number of physiological changes that must be evident in any effective movement data collection paradigm. And changes may take place due to muscle changes, age-related differences in hand laterality or dominance, and the inertial measurement units such as accelerometers and gyroscopes are sensitive to these task characteristics. So each task looks different and you're able to identify task-specific features. And they're also able to identify angular velocity differences in the two different aged groups and ranges of motion. And we found that the expanding Procrustes methodology is sensitive to the expected greater interlimb coordination as age progresses and potential evidence towards theory of delateralization or age-related acquired ambidexterity. Let's review two. Interlimb and intralimb expectation. Now to come back to our 6 different sub-questions that we asked of each aim. What are the significant descriptors of upper extremity motor performance? We found measures of movement speed, so mean velocity, movement of smoothness, so your angular range of motion, your initiation trajectories, which comes from the Procrustes analysis. Your scaling coefficients were also a significant difference, with subjects with more mild impairment doing slower and more stretched out movements, whereas people with more distal impairments are not able to sustain a more steady movement. Those were found to be significant descriptors of sensitivity between stroke subjects. We saw that coordinated movement can be quantified as temporal locations and lengths of segments of greatest congruency, and we are able to find where the earliest congruency occurs and where the overall percentage of similarity occurs. And they can be scaled in the case or delayed in the case of functional limitations or disruptions. So the temporal location will change. Our third question, how can motion data be segmented and characterized into phases of interest? We've had a lot of success using fixed sliding overlapping windows and Procrustean distance and point-by-point expansion, which combined with statistical shape analysis can highlight the phases of movement that follow our behavioral descriptions. Next, where we ask what parameters or methodologies would allow sensitivity to impairment severity is what led to the creation of the reach severity and dissimilarity index, with root mean square distance measures to quantify specific kinematic analyses and the Procrustean analysis to find rotation, reflection, translation, and scaling coefficients to qualify what those differences look like and where they're coming from. So will a quantitative score be sensitive to age differences and recognize multi-segment coordination? We found that age differences were consistently recognized across the subjects in both groups. We were able to consistently recognize them using the expanding progressive methodology. And finally, will a quantitative score be highly transferable to any clinically produced data, to any movement? And it was used for both symmetric and asymmetric bimanual and unimanual tasks. So we expect that this is a methodology that can be applied to other body regions as well. That brings me to where this study could go. This development of the Reach Severity and Dissimilarity Index, which utilizes expanding progressives to process segment movement data, create objective scores of severity and coordination and age-related differences, can be strengthened, by validation through the inclusion of other central nervous system injuries, so traumatic brain injuries, cerebral palsy, Parkinson's, multiple sclerosis. That would be a very necessary next step with this methodology to validate it with impairments that are subsequent to conditions other than stroke. Inclusion of additional kinematic metrics from that original flowchart, so increasing also movement smoothness is a very good descriptor of upper extremity movement. The very important next step for me personally would be the development of an at-home remote human activity recognition system. I began my work with stroke patients 2 months before the pandemic happened. And so these were subjects that for that time were no longer able to access rehabilitative interventions. So that was something I experienced firsthand. So I'm very passionate about the need to create a at-home remote human activity recognition system that is sensitive and individually customized. Because disability is not an experience that is monolithic. Every person experiences disability very differently. And potentially we might be able to harness accelerometers that already exist in our pockets every day. And finally, the biggest question is of perhaps introducing more data streams in order to differentiate between true behavioral restitution and compensatory movements, as that remains a very big question in upper movement performance analysis. And these are all our publications that came out of these studies. And just some acknowledgements. I'm sorry for the blurry nature of the picture, but I'm indebted, of course, to all of the subjects that gave their time and generously gave their efforts to this, to all of these studies. The members of the lab for allowing me to bounce ideas off of all of you. Dr. Michelle Harris-Love for introducing me to the entire study of human movement. Never be able to forget walking into her classroom and realizing just how rich study is of human movement, and we don't even think in order to move. And of course, the MedStar National Rehabilitation Network, all my committee members, I'm very, very thankful to all of you today. That is it. Thank you.
Great. Thank you so much, Khadija. A big round of applause. All right. So at this time, we'll open this up for questions from both the committee members as well as the audience.
Yes.
First of all, very good presentation, mashallah. I enjoyed it. So one of the questions that I have is, I know you did the measurement of the limbs of patients, and did the length of the limbs per group impact the asymmetry of any tasks, since that was not really mentioned in the slides?
Yes, so I looked at the different differentiators, the demographics of the both age separated groups. The only difference that had the only metric that was significantly different between the two groups was the age. The hand measurements generally, we had tall and short people in both groups. So that wasn't different between the two groups. In terms of impacting their performance, because each person's data was only compared to their own data, it still remained consistent what we were comparing in both cases, because we compared one person's right upper limb to their left upper limb. So the comparisons are still occurring between limb segments that are, I assume, the same size, accounting for any irregularities in just human development.
I think that's it for now.
Right.
Thank you.
Thank you.
All right. Other questions?
Could you go back to the slide where you showed, the comparison, I think it was I don't remember the page, was it 2036? Try 36. No, well, that's one of the ones I had a question on, so, but the previous slide, I think, was showing the, yeah, that's.
Yes.
Okay, so red was one arm and blue was the other arm, is that correct?
Yes, in these first two graphs over here, this is the forearms. I have more graphs later if you'd like to see
Yeah.
them that show both the upper forearm
Good.
and hand segments.
So those were the two arms. One was
Yes.
the right arm and one was the left arm, and
Yes,
then
these are the right and left forearms. These are the right and left forearms during the buttoning task. And these are the upper right, so dominant upper and dominant forearm of the same side during the cabinet task.
Dream characters, okay. And I just wanted to clarify that, and then you mentioned quality scores. Can you describe again how you got the quality score?
Yes,
So it would have been really helpful if you'd had like the equation or something on a chart, because you said it in words, but your words were going by and I was trying to read the chart and understand your words at the same time.
yes, absolutely. So the quality score is based on, we have our percentage of similarity, and I don't have this on this slide, but we also have the dissimilarity index of that congruent segment.
Now,
Below the two.
how exactly is a dissimilarity index different from a similarity score?
Dissimilarity indices are based on each ith element of each of those two curves that are
So you
compared to one another.
Rusty, and then you compare them, and then
Yes,
you
so the
get a.
Procrustes is done on those congruent segments that are found. That is the dissimilarity index.
Okay,
So
it's
that's
a-
from 0 to 1, with 0 dissimilarity, meaning that you have two identical sets of data. And 1 is complete dissimilarity, they cannot be conformed.
So once you've decided which of the two segments, how you match the two segments, the beginning and the end of the two segments, then you do the Procrustean to morph them into each other.
Mhm.
And then the dissimilarity index tells you how far from exact that transformation was.
Yes,
Okay,
yes.
and then the similarity score is what?
So the percent of similarity was done by that point by point expansion in either direction to find
That's
where.
the chart I wanted you to look at, point by point expansion
Oh,
chart. That there was a red curve and a blue curve and a black line. There was a. I had a red curve and a blue curve and a black line.
That was from the, yes, that was from the stroke.
That was the whole process. These are all normal subjects, okay.
Yes, yes.
But anyway, you do the point by point. And so this one is where you match up the points, and you do it the way you did on those. Is the way that you matched up the points for the similarity. The similarity score,
Mhm.
was that the way that you did it for the, I mean, I know that you had the healthy and the stroke, but do you match up segment by segment?
Mhm.
Okay,
So the difference between that second aim, we called it sliding Procrustes because it was only sliding across to find the earliest congruency
Right.
that occurs. So that was the intention with that was to identify if congruencies occur during movement beginning, the initiation of a movement, or towards the ending.
right.
So those did not expand. The slider remained fixed
Mhm.
in order to be able to compare the reference to the stroke subject.
Okay,
With these, there is still that sliding, fixed sliding overlapping window with the same 97% overlap to identify where that the highest congruency occurs. If it's above 15%, that's not considered a high congruency.
right.
If it's not temporally matched, it's not considered a congruency. So if it was found, let's say a congruency of 0.01 was found,
Mhm.
then there's a point by point expansion forward and backwards to find where that stopped being true
Okay,
for that person. So once that location is found, that's the percentage of similarity compared to the overall movement.
okay, so you have how much of the overall movement curve were they similar?
Yes.
Okay,
And
alright.
the dissimilarity index, so for a person showing a lot of coordination, they would have a high percentage of percentage of similarity, and they would have a very low dissimilarity index. So the quality score is the log of the percentage of similarity divided by the dissimilarity index.
Okay, so,
Yes.
low dissimilarity and high quality
Percentage of-
score
yes.
means that there's a lot of congruence,
Means there's more evidence of coordinated,
coordinated.
symmetric.
Okay, that makes sense. Now go to the table again. Okay, so you've got the similarity and the quality scores, and then okay. And so and I remember you saying in group one, you had more consistency in the quality scores,
Yes.
for the intralimb,
Mhm.
and there's more variability in group two.
Group two has has lower quality scores. There is
Yeah.
still intralimb. Of course, these are all able-bodied individuals.
Yes.
And group two is only 35 and higher. So not necessarily going to be people who show a very dramatic difference
Yeah,
from the 18 to 30 group.
okay,
But
but they are
they're-
showing less coordination.
Yes. Yes, and that was generally due to the dissimilarity scores. They had a greater amount of dissimilarity, even if they had the same percentage of similarity present. And generally, they're trending towards the first one has the highest percentage of similarity, the first task, because it's a completely symmetric, very, very familiar task to do. And as you increase in complexity, there is, interestingly enough, there is a better quality score for the older group, which is more similar to the quality score for the younger group. The most important finding was for interlimb, that there is no coordination occurring during buttoning and unbuttoning, but there was some for the older group.
I have a couple more questions, but I want to back off because I want to let other people have a chance.
All right. I have a quick question, but we can probably expand upon later on. So I think in the beginning of the presentation, you talked about this idea of constraint on motor abundance, right? So you brought up this idea that there's many degrees of freedom in our motor system, but there is some way of constraining that so that we can achieve these kind of tasks like reaching and so forth. So one thought is that, and this is not just our thought, there are several people now thinking about this, is that, the muscles are one piece of the puzzle, but then there's also connective tissue that's actually helps in sort of the force transmission from the muscle to the joint. And the connective tissue forms these chains that allow these motor constraints to be in place. And one of the things that have been found is that in stroke, there's actually some impairment in the sort of the lubrication and the connective tissue. So some of our collaborators are actually focusing on using hyaluronidase to increase lubrication and connective tissue to improve range of motion and so forth. So my question to you is that if the way you described it, which I thought was really interesting, that this coordination actually sort of persists into later stages. So in the impaired group, right? So if I understood it correctly, in sort of your control subjects, you have higher coordination in the upper, so more proximal joints in the initiation of the movement, and in the distal joints that breaks, and then it allows you to sort of do this kind of fine control at the end, right? Is that what I understood? Whereas in your impaired group, that dichotomy is no longer there. You essentially have this coordinated movement throughout the entire phase. Is that what I understood correctly?
So the initial time that we showed that what I can just for now call synergy. Of course, synergy is not necessarily described as just two limbs having covariance or showing the same kinematic parameters. As many contemporary studies show synergies as a covariance or as kinematic parameters changing in a similar way. So yes, in the first study, we saw that there was a movement synergy or a similarity in how movement was progressing during movement completion between the upper arm and forearm segments during fine control. And if we compare this to the subjects, that fine control either does not happen due to increased distal impairments. Greater spasticity would also affect the ability for this congruency to occur later on in the movement. That could be one potential reason for that. But also it could be due to maladaptive compensatory movements. So the limb as a whole essentially is frozen together in movement because of joint stiffness or reduced range of motion. So that could be another potential explanation for why this synergy, rather than occurring at the end of the movement, is occurring earlier. So this is not actually recovery. A lot of our statistical analyses were all one-tailed because with impairment, you do not expect the person to get faster. You don't expect them to show coordination sooner. So this could be potentially a way to identify time location, could be a way to differentiate between true recovery versus compensatory movement. So our assumption here is that this is some form of compensation or some form of maladaptation.
And of course, spasticity plays a role in all of this too, right? So,
Yes, absolutely. Which is
so the
so much
spasticity,
more evident.
right? Okay. Well, we can talk about this a lot more because this is fascinating to me, at least. Are there any other questions from the audience of the committee for the open session?
Just quickly to follow up from Dr. Sikdar's question, did you see, were you able to observe the subjects to see if you're seeing more compensatory mechanisms for movements?
Yes, we were able to make behavioral assessments of the person moving. The Fugelmeyer assessment, along with the NIH stroke scale, all of those were done by trained clinicians, but I was present during those and was able to see what they considered a significant behavioral observation. So one of the observations that was described to me, and I was told, watch out for this movement, was the trunk or shoulder involvement in order to compensate. So generally, when a person cannot extend the elbow forward and uses, a displacement in the Z-axis and raises the shoulder, that is considered by clinicians to be a compensatory movement. So I was able to see that. I was also able to see the range of motion being constrained. Despite the increase upwards, it wasn't a rotation of the arm, but rather a shoulder being raised. And we saw that both objectively in the data and also in person. There's also a gradient of impairment that exists with distal impairments being greater in severity. You'll see people are more able to extend the shoulder, less able to extend the elbow, and even further less able to extend the fingers. So the severe group actually also had an inability to extend fingers past 20 degrees of neutral position. And that was one of the great classifiers between the two groups of who was in the mild impairment group and was in the severe.
Yeah, I was wondering if subject 1 say versus subject 2, did you see one have more compensatory movements versus?
Absolutely. And what was really fascinating is some of these subjects had lesions in pretty much the same location of the brain. And there was really no way to differentiate from their MRIs who would be the more severely impaired individual. And it was really seeing them, and also quality of life is a big factor, and social functioning was a very big factor in how they self-reported their level of disability. So definitely this is very much not a normative study, because it's not looking at what is causing these behaviors. It's very much behavioral, looking at the behavior and then hoping that the mechanistic and normative studies will be able to explain what we're seeing here behaviorally. So there's definitely none of this can be studied in isolation.
I'll just go with one question. I'm curious about the feasibility of applying the analysis for monitoring individuals' progression or rehabilitation improvement over time. Do you think this has the enough robustness and sensitivity to detect subtle movements that may be harder to be seen by using other technology?
So some movements in especially the upper extremities, sometimes they are obscured by other error correction occurring at the same time. So it may not, I don't believe that in isolation this would be able to identify a specific movement and distill it from the rest of the movement. So it's very possible that this again, I don't like calling it a synergy, but this congruency could be holding multiple things happening in the person's motor apparatus at that time. Generally towards the middle of a reaching movement is where subcorrections occur. And where sensory feedback is incorporated into the movement. We generally move really without thinking in the beginning, and it used to be called ballistic movement because it occurred in the absence of any feedback. And then the feedback is incorporated as you see your arm go closer to the target. You might increase the aperture of your hand as you get closer and realize you need to have a wider grasp. You might correct any error in targeting that might have been done. So it's kind of an in-between phase between gross motor and fine motor. And this could be hiding many things that are happening at that moment. So it is not sensitive to that, but it is able to find during the continuum of data where two segments are doing the same thing.
Thank you.
So I find it interesting when you're talking about the compensatory motion, like of the shoulder, etc. Does your dissimilarity metrics where you're comparing subjects with healthy non-impaired controls, does that pick up things like the shoulder displacement, or is that the separate thing? Is that part of the score? Does it come in there?
So that was Z axis displacement, and we didn't include it in these scores that were here. So that's one of the future.
But you could imagine coming up with a score that detected these compensatory movements, and the therapies could be directed towards helping people to learn to do it without the compensatory.
Absolutely. And in the literature, what's interesting is a lot of the trunk and shoulder involvement usually gets quite underestimated. So errors that are caused by that, they generally aren't incorporated. We are able with this methodology to apply it. So all of the applications that I showed you here were three-dimensional, but you can also apply them to just the Z-axis, which is where all the trunk movement or shoulder extension would occur in the more severely impaired group. So that is something that this can be applied to.
So both this hypothetical future index and the index that you developed, one of the advantages of being a quantitative sensor-based metric is that you can compare a subject over time in an objective manner and determine progression towards improvement.
Absolutely. So right now, what clinicians will do is after a amount of sessions of rehabilitative practice, they will apply the Fugl-Meyer all over again. And these are simulated activities. They're not actual functional activities that they're carrying out, which are not a very good representation of how that person moves during their day-to-day activities of living. So these, and the Fugl-Meyer takes a while. You need to have a licensed trained clinician to perform it. So if you are trying any kind of movement at home to see if it's creating any kind of improvement, it's not something that is being necessarily detected by the Fugl-Meyer. That person might still score you. For example, 0 is you were not able to complete the move. 1 is you completed it, but with difficulty. And 2 is you had no difficulty in performing it. So one clinician might say that this person is still just a 1 and it is not showing improvement. However, that person might be gaining in strength, might be gaining in recovery, but would still be scoring a 1 on that subjective scale. So one of the advantages of having a quantitative objective score is that it can be applied to any motion data that is created, not just simulated activities. So it can be collected while you're actually living. If you use a at-home recognition system like fitness trackers have accelerometers in them, our smartphones have accelerometers in them. So you might be able to harness that, harvest data during activities that are actual activities of daily living, actual functional tasks, and be able to compute a score over time without having a clinician who needs to give you that score, and without having to go to the same clinician in the same lab with the same materials. And even that doesn't necessarily mean that they score you differently.
So I can imagine, like, just like you have on your Apple Watch, you have your circles that you're trying to complete. Maybe you have your Apple Watch and you have a metric that you're trying to, a target metric you're trying to reach with your exercises, and that might gamify it kind of.
Absolutely. I saw this one app that was beginning to think about rehabilitation with an iPad where they had subjects try to trace a line. It really very much could be gamified, and the data from that can be used to create scores to tell the person over time a score that is more intuitive to them than a Pupil-Myers score. The 37 is not really different from a 38 to a 39 on the Pupil-Myers, but a person might, and that's a social functioning is actually a very big part of rehabilitation as well. I've seen studies where people who are alone tend to just not even use their paretic arm. But if there's somebody around them, they try to make the effort to exercise the paretic arm. So social functioning is a big part. Gamifying recovery would really increase patient compliance. Compliance is definitely a very big issue. I myself noticed I would arrive at the MedStar hospital and be told the person doesn't feel like they can move today, so they're not going to come in. So there's a lot of difficulties along the way when you're recovering from a stroke. So having something that's remote, that is patient guided, that's individualized to that person, really is what's necessary.
Could imagine having groups of patients that provide each other with emotional support and, cheer each other on.
Absolutely. Yeah, it was a really interesting story and the research study. And I feel like, with my grandparents as well, I noticed that if my grandmother was around, my grandfather would feel more pressure to try. But otherwise, if you're alone by yourself, you are going to compensate. You're going to not put yourself through rehabilitative intervention, and you'll try to get the objective of the movement done. And that's where a lot of maladaptations come from, that they tend to begin to favor certain movements and not practice something that they do have the potential to recover.
Excellent. Well, at this time, I would like to thank everyone for attending, and we will have the committee have their executive session. So thank you again, everyone.
Thank you very much, everyone.
Khadija, do you want to take a 2-minute break?
I will just take a sip of water. Yeah, keep it.
See, you could send all the other people into the breakout room.
Yeah, but
Or I can just remove them. I don't think we need to have them back.
that's what you need to have about.
They might want to come back to the.
Okay, for waiting room. So I think we have the. You cannot do that, on the side. You can do wrong with it. So I'm saying for the.
I think Carol might be the one to do that if she's the host of the.
Oh, for me, should we maybe the host of the. Make it stronger. Here, I think I can. Put in waiting room, yeah, if there's somebody else also. In waiting room, what is going on? A lot of people going online, Khadija, you better realize a lot of them. Oh, there's the one.
I'm actually the fourth in my family to attempt a PhD at this university. So not only do a lot of my family members still get the emails, they have been through it. So a lot of them were interested in attending.
Wonderful. I think we have